So good afternoon and welcome everybody. My name is Tio Quay. I'm Assistant Director Research at UBC Health, and I'm very excited to welcome you to today's Health After 2020 dialogue session. Firstly, I would like to humbly acknowledge that I'm joining you today from UBC's Vancouver campus on the traditional, ancestral, and unceded territory of the Musqueam people. I'm grateful to recognize that UBC's activities take place in community on the traditional territories of numerous First Nations and Métis communities, each with their own unique traditions and history. And the work we'll be discussing today also reflects the knowledge and contributions of global communities, so we recognize the lands and voices that have informed this work. So just a little bit about UBC Health before we get started. UBC Health works under the Office of the Vice President Health to facilitate collaboration across disciplines, faculties, and campuses, as well as with health partners and communities. Our aim is to improve how we train people, develop knowledge, and shape policy to advance equity and improve the systems that foster and support health. So through our research initiatives, we aim to support an active community of health research practice and mentorship, bring together scholars, students, and community partners to discuss important topics related to the health and well-being of society, and advance interdisciplinary knowledge translation. So the Health After 2020 program was developed in response to the evolving understanding of health, which was accelerated by the COVID-19 pandemic. So through its 3 cohorts, the program has supported 23 interdisciplinary teams in advancing collaborative research, engaging with broader communities, and participating in a community of UBC Health scholars. The 3rd and final cohort is supported through a partnership with the UBC Knowledge Exchange Unit that aims to build capacity and innovative approaches to putting knowledge into action. And so while the program is wrapping up, UBC Health remains committed to fostering collaboration, knowledge mobilization, and interdisciplinary engagement through other initiatives and emerging opportunities. Today's session exemplifies these commitments by showcasing innovative approaches to knowledge translation that honor local traditions while embracing modern communication strategies. It'll highlight how research on women's resilience during the pandemic was transformed into accessible, culturally relevant formats through community co-design. So the Chamas intervention reimagined traditional academic findings into engaging formats, such as storybooks, children's activity books, community theater, and youth-focused social media content. And the team today will share insights into the co-design process, strategies for effective knowledge translation, and explore how partnerships with local universities, community advisory boards, and design labs create sustainable models for knowledge sharing. And so through interactive discussions, we'll examine the impact of storytelling and performance in knowledge mobilization and how these approaches can be adapted to different contexts. So leading the session today, I'm going to pass it over to the team. We have Abiola, Anjellah, Justus, Nadia, and Astrid, and they will introduce themselves and get us going. So over to all of you.
Well, good afternoon, everybody from Vancouver, and we are so fortunate to be presenting here from Vancouver and then all the way to Eldoret, where our colleagues and friends Justus and Anjellah are presenting. And they are zooming in from midnight their time. So I don't know if that's good morning at 12:06 a.m. or if that's good night, but certainly it is a very generous gift that they've stayed up to be able to join us in the presentation today. I'll start off and just say my name is Astrid. I'm an obstetrician and anthropologist and work in the population health promotion team at BC Women's Hospital. And I'm also on call, so there is a chance that you might hear a different kind of storytelling if I'm not able to turn off the audio of someone in labor. So I apologize already ahead of time if that should happen. And we're really excited today to have this opportunity. I really want to say thank you to UBC Health for this opportunity. When we saw this grant opportunity, I'd encourage any of the researchers here to think about applying for this. It really has allowed us to extend our funding possibility or our ability to do research well by ensuring that we have the time and the funds to be able to take the findings that have been generated and think of how we might translate that into the various languages necessary for different audiences to be able to benefit from the research that they themselves have participated in. Before I hand it over to my colleagues to present, and in the small chance that I get called for a quick delivery, the main message we wish to share here is that as researchers, just as all aspects to our lives, our language really has a big influence in shaping people's experience. And so I come at it from being at the bedside on a daily basis and really seeing how my words will shape people's experience in the moment. And I think as researchers, we also are at the bedside in different ways, sometimes very far away from the people who are there, but they can feel quite close as we engage in that knowledge translation process. Imagine, how might we present to an academic audience? How might we present to our peers? How do we present to the person, on the airplane as we're going to an academic conference? But most importantly, it's how might we have that extra bit of time, that little bit of funding that allows us to actually bring that story, create that story with people who have participated in the research process. And so although I'm anchoring this funding and this grant here at UBC, I really want to acknowledge that I play very little role in making that story, and have really been impressed and humbled and delighted to see how stories that are generated at that bedside from people themselves that reflects their experience can convey a truth and a reality that in itself is so important to how we do research well in our community. And so we're hopeful that today's presentation gives everybody that little bit of spark to say, let's figure out how we might ensure that people have a chance to look at the findings, see if it makes sense, and then how that story needs to be crafted and shared in a language that's going to make most sense to people in their community. I'm going to pass it on to Justus and to Angie from Eldoret to present themselves.
Thank you so much, Afik, for that introduction. So my camera is not working, so I'll try to use Anjelah's camera. So I don't know if you guys can see me. Yeah, so that is Justus. So I think I'll give a little bit of a background on the program that Asid passionately talked about, so that it gives. So that is Justus. Yeah. So thank you. So just to give a general background, so that we have an understanding while we're having these exciting discussions, so that we understand the background of the Chamas program. So the Chamas is basically a Swahili word that means a group, mostly groups formed with a purpose. And that is something that is very, very common in East Africa. So, and we took advantage of that infrastructure to transform lives through using the same infrastructure to have a service that would improve the health of women in the community in the first 1,000 days. So we just use the existing infrastructure to improve their lives. Now, so generally, who and what is the criteria for you to be involved in this exciting Chamas program? So one is you have to be pregnant. And the reason why that is because in our context, women who are expecting go through a lot of challenges. The activities that you're supposed to carry out as a mother still continues regardless of the fact that you're pregnant. So we look at these women as vulnerable, and our idea is to make sure we take care of the most vulnerable. So the second thing is you have to be someone who has limited access to essential services. And given the fact that we are targeting women who are living in rural areas, who are living in slums, people who find it difficult to actually access healthcare and financial services. So we are targeting the vulnerable. So essential services are very, very important. The third thing that we're looking at is generally looking at their poverty levels, and we look at who are these people who are living below the poverty line, and how that they would want so much to contribute to their families, but they have limited access to income and as well as in terms of having financial access generally. So the other thing is there's a lot of lack of peer support. So we target these women because during pregnancy, so they have to navigate so much in their lives because their responsibility still remains there, and there is no support, and there's no creating that connection sometimes becomes difficult. So we target them so that we can provide a connection with other women who are in the same situation. So the other thing that women face in our environment is actually limited power and autonomy, because most of the decisions are made by the husband. So they feel like they have no power. So the program looks at how do we support them to give them power to make decisions, and providing all this education, providing them a platform where they can learn and borrow gives them power. So what are the components of the program? So when these women join a program, there are several things we're looking at. One of them is providing them with health education. And when we talk about health education here, we use already existing infrastructure. Here we use the term community health promoters. In other regions, they're called community health workers, depends with the region, because these are people that are actually available within the healthcare system, makes it a little bit cheaper and sustainable as well for the program to share knowledge and discuss among themselves on things regarding their health and their own well-being. So the second component of the program is actually social support. And initially, when we started the program, our focus was mostly in health education, but we had a discussion with women to say, if you want to have this program, what would make it more interesting apart from having health education? Then they told us, if you can have components of discussions around social, our social well-being, our social health, it will make the program more interesting. And we incorporated that as well as part of the component of the group where they discuss about their social life. And then the third component is microfinance opportunities. And why this is very important is because in our context, access to loans and savings, and especially loans, is not easy. So because most of the time you need collateral, and most of our communities, women do not have something they can put as collateral to access funding. So these programs give them an opportunity to loan among themselves because they have confidence in each other and they have trust among each other. So this gives them a platform to do that. So, and we're looking at this not just as an individual, so we're looking at it both as individual empowerment and group empowerment. So as part of the program as well, so we have to play to something. So as part of the program, women play to several things. So, and in your screen, you will see only 5 things, but it's more than that. But the most important ones that we focus on is, one is they have to attend at least 4 antenatal care visits. I know now based on WHO, they're supposed to be 8, but we are still struggling with reaching 4. So we just want them to pledge to say that they are going to attend 4 NC visits, just to make sure we identify early in case there are any complications that might arise. So, and then the second thing is they have to pledge that they deliver in a health facility, and not just in a health facility, but also with a skilled birth attendant, so that they can be taken care of. So the third thing is they also need to pledge that they will exclusively breastfeed, because in our context as well, there is a lot of theories and misconceptions around mother's milk not being enough. So we have that education around that, and then they also have to commit that they will exclusively breastfeed their kids for the first 6 months. So the other thing is they also need to pledge to plan their families. And this is also important in terms of planning themselves financially, as well as making sure that they know that they can take care of their families if they plan. Then the last one on the screen is to enroll on government health insurance. So it used to be called National Health Insurance Fund, but now this has changed to Social Health Insurance Fund so that it covers for their healthcare, because for most of us in these particular settings, we say we are just one disease away from poverty. Once you get ill without insurance, then most likely we'll be put into a poverty situation. Next slide. Yeah, so and then I remember, and Astrid, when we started this program, initially we thought this is going to be a one-year program, but because of how exciting and how women wanted to continue, it ended up being a 3-year program. So, and in year one, when women enroll when they're pregnant and enroll through a community health promoters, we focus more on discussions around maternal and newborn health, because the women are pregnant, and those are the topics that are important at that particular phase. Then in the second year now, we move to how do we make sure we plan our families? How do we make sure we take care of our kids? So now we mostly focus on family planning and talking about child immunizations and how to take care of a child at an early age. So these are not the only topics. There are additional topics but now focuses on taking care of a child when the baby is still young. And then for the third year, remember when we started the program and had the first year, then second year, the women kept saying, we want to be part of the group. This is an exciting thing. Can you get something else for us to do? Now, that's where we started a parenting program that looks at positive parenting, and as well as trying to focus on, you've been part of this microfinance from year one, year two. Can we talk about how do you start a small business, a form of sustainability? So those are the first 3 years of being part of the program. And then after that as well, so we actually moved them now into doing more of microfinance and business fully as a form of continuing meeting, because there are groups that, given the fact that they love their peer support, they love the being the connectiveness that they have built, they have continued to be together and build their business empire for the past 8 or 9 years. Next slide. So I think that's it. Thank you so much. With this now, I think I'll pass it to Astrid. Thank you.
So Justus dove right in there into a program that we all have been part of, and he is our overall program manager at AMPATH, which is the academic model providing access to healthcare. And that is a global health collaboration between academic medical centers that is anchored by Indiana University. And welcome to our guests that are zooming in from Indiana University today, and is supported and partnered with several North American universities, including University of Toronto, through which we have been doing this work in Kenya. I just thought before we keep going, whether anybody has some questions about this Chama group model that we are discussing here, because this is really like a health promotion strategy that really was focused initially on how to cut preventable maternal and infant mortality back in 2011. And over the course of the last 14 years has gone from pilot to validated in an RCT in a population of 1 million people to now really emerging as a gender transformative health promotion strategy for families in rural and peri-urban communities in Western Kenya, where maternal mortality and infant mortality remains unacceptably high, but also where we see the importance of making gender inequities visible to achieving health goals for all. I just thought I would take a minute just to see whether everybody is understanding this model of Chamas where people can enroll and be invited to participate at the time of their pregnancy, and they might continue for the full 3 years of mentorship, or maybe they join in once their kiddo is born after a year. And it's led by a community health worker that's known to them, and they meet every 2 weeks. Any questions from the group so far? So Angie, who's also going to be speaking, is our program manager for the Chama program itself. And throughout the presentation, you'll also hear from Abiola Adeniyi, who's our postdoctoral fellow here at UBC, as well as Nadia Bezai, who worked with us in her role as a designer with initially the Health Design Lab at Emily Carr University, and now works as a health design consultant. Our goal over the next hour or so is going to be talking to you a little bit about our knowledge translation journey. So how did we get from asking some questions about how Chamas have worked through this time of COVID to mitigate the effects of COVID on communities and especially on women's lives using an intersectional lens. And then workshopping with you guys how one might take that journey and think about, you know, how you might want to co-create or really facilitate that storytelling from beneficiaries or of the program or participants in your research. And then finally today, we hope to share our thoughts about how we are looking forward. So this is really the space in which Chamas often take place, in someone's home, away from the sunshine or under a tree. And as you'll see, it's usually groups of about 15 to 20 women, sometimes pregnant and carrying their infants with them. And it usually starts off with the community health worker leading a discussion around a particular health topic and then a social topic. And then inviting then the leadership of the group to change to the women themselves, where they then pool together their resources, account for everybody's contributions, and then decide amongst themselves who is going to borrow that money. So it's a little bit like a Shark Tank, if you've ever watched that on television, where people get to propose, like, I want to be able to buy 5 new chickens. I would like to be able to do a sewing course. I saw this awesome beauty school. I would like to be able to try and do that. And they borrow it at an interest rate that is far more favorable than what they could ever receive through a bank, with the responsibility and the obligation to pay back ideally within a 3-month period of time. And part of those contributions also can go to any kind of catastrophic need for money, so that if someone's kiddo is sick and they are not able to, pay for out-of-pocket expenses for medications or others, there's a way in which they can borrow money from that group without any interest and returning it to the group at a later stage. I'll say at the end of the year, people are paid in dividends based on how many contributions they've made, and those dividends come from that small interest that gets charged. And we facilitate wherever the group would like those dividends to go. And so throughout the year, we work very closely with the groups to encourage them to try and save or imagine putting that money directly into their kids' tuition fees at the end of the year, or putting it directly into paying their next year's worth of health insurance. We try as much as possible to discourage people from using the dividends that come in December on purchases such as Christmas gifts. And we found that that meant that support in trying to make it easy for people to make their contributions for the next year's health insurance or for their kids' tuition fees has really been well appreciated. Any questions about the Chamas and the model itself? All right, so I will pass it on to our next member of our team here. We're going to try and get you guys to help us out with some questions here.
Lindsay, if you want to deploy the poll, be ready. Angie, you have the floor.
Yeah, thank you. So thank you all for being able to join. And to set us up as the poll is being pulled, just to appreciate the power of partnerships, because through the partnership with the UBC, we've been able to make lots of progress and strides in terms of our knowledge translation strategy. So as we continue, please feel free to fill the poll in before we move to the next slide. So we'll give it like a minute to 2 minutes for us to get responses from everyone before we can proceed to the next slide. So I'll pause for I think a minute to allow everyone to fill the poll.
The poll has ended, Angie.
Thanks, Abby, and thank you for everyone who's been able to fill the poll. So just to take us to the next slide.
And we can maybe
So
just summarize quickly, some of the results from the poll so far. And so I can see it on my end. And so the question kind of was around, how do we prefer to learn health-related information? Astra kind of went an overview of sharing, within the trauma session that's done in a kind of community setting live with women and their families. And so, taking a poll from everyone who's here so far, it looks like our top result so far is visual and infographic-based information. So that being posters, fact sheets, comics, illustration guides, and audio-based was, I think, the second top one, as well as video and motion graphics and written content. So looks like a range of different information can be accessed by people and is of interest. So just as an update from who joined today, that's where we're at, and excited to take that into the next pieces here. So Angie, I'll pass it back over to you.
Thank you, Nadia, for that overview and bringing us up to speed with what that looks like. So actually, most of what we've been able to vote in today is a reflection of what we also saw from the data that we collected from the communities out there. And just to bring that into context, allow me to share this framework by NatBeam on health literacy. And it has like different components, but basically health literacy is the ability to access, understand, evaluate, and use health information effectively. And health literacy is essential for making informed health decisions and improving health outcomes. So it draws us back to the amazing introduction we had by Justus and Astrid on the Chamas for Change model, which is built on the aspect of health literacy. So just to look at the different representations or categories that are reflected on this health literacy model, looking at the professionals, organizations, individuals, and being able to work on a model or strategy that does not just allow access only. It then leads to the aspect of this population being able to understand and effectively use whatever health information that has been shared with them. Next. So again, we will be reflecting on a few experiences here and there that we've had. And here, I just want us to think about a health message or research finding that has made a real impact on you or your community. So with that, thank you for pulling that up. So we can still do the same thing we did earlier of being able to answer the different sections.
Ended, Nadia.
Okay, so I see from the how did we first receive the health message? It looks like, interestingly, in contrast to the question before, where it was how would you like to receive health information, it being more visual related, it looks like our top response is mostly in a written format. So in books, reports, articles, pamphlets, and as well as kind of like audio and video-based content following that in second place, as well as visual information kind of as well there. Okay, in terms of the responses, okay, I think we saw 10 people responded to the key messages and 10 as well. I'm trying to see if we can summarize live here to see those responses. I might ask the health.
Yeah, I have it up here if you'd like me to give a quick overview. So for the key messages, I think I'll just give a few examples of what we're seeing. Safety of antidepressants in pregnancy, rate of transmissions in COVID demonstrated through live data visualizations, just basic messaging about hand washing, being kind during COVID, messaging to get a COVID vaccine and how to flatten the curve, I'm assuming during COVID as well. And then some commentary on what made these messages effective. Someone commented on combining different modalities, so posters with QR codes to watch videos, pamphlets with supporting info, short videos about the topic, playing in women's clinic lobbies. So I think a multi-pronged approach. Using data visualization to make the data more digestible and impactful, clarity of the messaging. I think also someone commented short and succinct. So again, those kind of clear bite-sized messages, and also just the relevance to the current context, the right message at the right time, and really grounding things in real-world examples. So just some of the feedback that we received, and I'll pass it back to you, Nadia.
Awesome. Thank you so much. So quite a wide range of approaches, it looks like, in terms of what was effective. So good to hear what has worked for everyone so far. And we're excited over the course of this presentation to share what has been effective for this project. So I'll now keep us going.
All righty. I think I'll jump in and then take us on to how we were able to move from research data into translating that into something that can be used at community level. So this next section is going to focus on our processes for knowledge translation with the Chamas study. Next slide, please. Before we go into what we found from our research, I just wanted to share with you a little bit about our context. Our research took place in Trans Nzoia County, Kenya, and it was part of the IDRC Women Rights Research Initiative that spanned 2022 to 2024. The initiative focused on women's resilience during COVID-19 pandemic. And on the screen, you can see a map of Trans Nzoia. It's in the western part of Kenya. Really beautiful place. If you've never visited, I really, really want to encourage you. It's very lovely. On the right, you can see the distribution of our study site with the green dots representing our intervention clusters. It's as much as Chamas is a very good initiative, we're aiming to have it all over the country eventually. But at this point, we only have it in certain areas. And the other areas that are in red dots are the control clusters. The black dots show the linking facilities. And this diversity has helped us to sort of work between a rural and a semi-urban setting. Next slide. And also to help you understand where we're coming from, we thought we'd share with you the aim of our IDRC-funded study. The study pretty much had three aims. First of all, we were interested in using co-design approaches that would really bring forward the voice of the community and really emphasize what their needs were. So we had to set up a community advisory board to help us co-create the research methods and how to disseminate our findings when we got to that point. Secondly, we conducted a mixed method study. I want to say that we're focusing a lot on the qualitative aspects of our study in this presentation, but we used the mixed method approach, which included a quantitative study that was done using survey questionnaires, amongst women. And then we also had a qualitative study, which provided the information that went, a lot of which went into our storybooks and our other knowledge translation strategies. Finally, our third aim was to disseminate these findings back to the community. A lot of research has been suggesting that it's the knowledge translation piece that has struggled in terms of the things we find in research that is conducted at community level. So that was one of the foci of our research with the IDRC funded study. Next slide. As I mentioned earlier, our first aim had to do with having a community advisory board. So central to all that we did in this study, we had this advisory board that was formed, and it included people from academia, from clinical practice, and members of the community. We had adolescents represented, pregnant women or community health providers, just a wide section of people who were informing how our research was going to be conducted in the community. They were invaluable in giving us the contextual piece for this research, and in also ensuring that all our approaches for collecting data and for even interpreting the data was contextually relevant and considered cultural sensitivity in every way possible. So that was really important. Next slide. For our study methods, as I mentioned earlier, we did use a quantitative approach, and we were trying to find out whether the Chamas intervention made the women more resilient than in the community than those who hadn't participated in Chamas. So we had quantitative data collection among women who continued to participate in Chamas throughout the COVID pandemic. Those who dropped off formed another cohort, and the third cohort were women who had never participated. If you remember the slide I showed you of the study location, we have three clusters, those who had participated and those who hadn't participated. So in total, we engaged with 609 participants. 124 of these women continued to participate in Chamas throughout the pandemic. And our hypothesis was that participating in Chamas during the pandemic would increase their resilience in terms of health and in terms of their economics and even in terms of their psychosocial status. So we got data on these three components. We're in the process of writing up our research findings, and I will share some of our findings in a couple of slides ahead. But for the qualitative piece, we had data collection from two strands using focus group interviews with a subset of the community. And then we had 11 key informant interviews to sort of help us understand the processes within the communities that were used to support people, just apart from the perspectives of the women, their spouses, the community health promoters, and even adolescents. So we had focus groups with all this variety of people. In all, we had about 84 participants in our focus group discussions and 11 key informants. Next slide. One of the things that Astrid spoke about when she was describing our approach was that we used an intersectional approach and a gender-sensitive approach. And to help us really ground this, we used a gender and COVID-19 matrix. And that's what is summarized on this current slide. The matrix has 5 key domains, and we've tried to understand how gender intersected with each of these domains. So our quantitative data helped us do that, but our qualitative data was where we really honed into kind of tease out how was gender playing a role in the patterns we were seeing with the quantitative findings. And a lot of the quotes and experiences shared within this category, they became building blocks for our knowledge translation piece, as will be shown as we go on through this presentation. Let's move to the next slide. So what did we find? Summarizing our findings, both from the quantitative study and the qualitative study, we found out that Chama participants were more likely to be supported postnatally by community health workers than non-Chama participants. About 77% of them reported receiving a postnatal visit. And this is something that is considered statutory in the Government of Kenya Antenatal Guide. 88% of Chamas members exclusively reported breastfeeding their babies for 6 months. This was in contrast to 36% of the control group. So we found out that in these two parameters, the Chamas women were faring well. But in terms of economics, all the three groups of women were similar. There was no difference, right? But interestingly, we found out there seemed to be a higher report of gender-based violence in the community. But what was interesting was that women who continued to participate in Chamas seemed to be more comfortable reporting gender-based violence than those who dropped out or those who had never participated. In terms of resilience factors, we found out that having engagement with the community health worker was something that seemed to help our Chamas women cope better. And they seemed, one of the things they reported was having access to correct and accurate information in a timely manner. So that was really great to see. They also spoke a bit about the financial support they would normally get by through the financial component, but this didn't quite reflect in their economic indices. Next slide. I just thought I would tease out a bit more on the gender-based violence as an exemplar of how we were able to then bring our study findings into the knowledge translation piece. We found out that during the COVID-19 lockdown in particular, being in close proximity to family members seemed to create more opportunities for gender-based violence. And there was a lot of comments around job losses, increasing the incidence of gender-based violence because of the greater financial stress that was in the community at the time. Children also were not spared from these experiences. Right in the middle, I'm presenting the quantitative findings on gender-based violence. 24% of cohort A women, which were the women who continued to be in Chamas, reported experiencing gender-based violence, while we had 17% amongst those who dropped out, and then 14% in those who had never participated. The thing we thought made sense was perhaps the women in Chamas, because they had spent a lot more time together as a unit, felt more comfortable sharing their challenges than those who had either not participated or had dropped out. I just put up a few quotes from the data just to exemplify what we heard from our participants. Next slide. And I think I'll just hand it over to Nadia to then describe how we took our research findings into the knowledge translation piece.
Thank you so much, Abiola. And so, yeah, I'm really excited to kind of walk through what this process looked like from a, research perspective and shifting that into kind of a design lens and how we met with the team locally in Kenya. And so where Abiola kind of left us off was looking at, we collected information through this research study from focus groups and key informant interviews and analyzed that data, which was a really comprehensive process, coded in en vivo and summarized and shared with the team as a way for us to really, be the starting point for this next phase of how do you take that really dense academic type content and then translate it in a way that's not only beneficial for the academic and research community, but also the people who participated, who are those individuals and families and moms and kids from Transoya specifically. And so what we did as a team for, across 6 months leading up to a kind of an in-person session where we all gathered was reading through the transcripts and soft coding the information to make sure that all the members on our team are really familiar with the content and some of the core things directly from what people said as quotes. And so that was really important for kind of context setting. And here in green on the slide, I've kind of split up a little bit things around, context, building relationships, establishing that information as a team and for everybody on the team was a really important first kind of step as we moved to the knowledge translation piece. Another core piece here was also recruiting local talent. And so myself, I'm joining in from Vancouver, and we have some other people that are also from Vancouver. And from a design perspective, it was really evident for me that, having students locally from Vancouver or even myself kind of trying to translate that content wasn't going to be kind of really feasible. There's so much local and cultural context that's really necessary. And so having some local students from Moi University, which are from health communications, joining who are kind of in their undergrad degree program was really an important part of this process of bringing that local knowledge into this aspect of the project, where they're kind of supporting the knowledge translation and also having an illustrator who's local in Kenya to be part of that process. So this was kind of leading into a 1-week session that we had that was a kind of co-design crash course of us joining in together in Eldoret, where we then had a visit to different health facilities as well as Chamas sessions. So the photo that you saw earlier from Astrid when she was speaking about the program was from last year in Trans Nzoia specifically. And that was kind of to look at, what are people doing locally in those sessions? How could we think about that context as a way that we want to share back content to later on in the process? So that was really important from kind of a community lens to see that as a full team, and also bring the students that were involved in that process to see that before we jumped into the findings. And then further kind of other things we're looking at, again, that gender matrix, looking at storytelling and research, looking at the findings in a summarized way, and also looking at literacy and what that means in this context. And so that was kind of what set the stage for us then jumping into setting some design constraints, which we'll walk through in a second, looking at what does it mean to make a story and how does that look like in research, as well as building a kind of visual identity for this project and for the knowledge translation specifically. In addition to kind of bringing all of that content now back to the community advisory board, rather than designing in isolation and just sitting with our team. It was really important to have these rounds of feedback where we continuously made sure that whatever we were moving forward got further kind of like confirmed or adjusted by the community and those that were on the board. And so we had done a kind of session where we reviewed the stories, we'd gone through the visual identity, we read through this, read through the content we have developed, and then came back as a team and looked at how can we look at not only storybooks as an output, but different media options that are digital, that are play-based. And so we'll walk through that in a second a little bit more. And so where we are kind of now was, we had set a plan for the team to kind of keep working from that 1-week intensive to refine the stories through multiple rounds, and then also kind of creating the media, the final media outputs for that. So we're in that kind of phase of the project, and we're excited to kind of share through this presentation where we are so far. And so that's the overview, and I'll now kind of just jump in quickly into each of those steps so you can get a closer picture. Okay, and so for design constraints, often this is a good exercise to do with a project where you're kind of setting the intention at the very start of, what do we want to do as a team? What are we trying to accomplish? And not making assumptions that some of these things are kind of obvious at the get-go. And so we knew, of course, from the main aim of the study that was shared earlier, that the goal was to share the research findings and some of the core ones that came out. We also knew that we wanted to engage members of the family and all members of the family, considering different family structures, and kind of acknowledge that it needed to be accessible to a primary level of education based on the literacy kind of statistics that are available for Kenya and specifically the Trans Nzoia area, as well as kind of being accessible in 2 languages. So in Swahili and English, and for anything printed, that we made sure it was durable to bring back to the different communities, acknowledging there's lots of rain in the area, and having it that, if we use it once, we can have that longevity of years in the future to bring it to different sessions or in different contexts. Also the focus of the team was looking at, how do we make things that are less text-based and more image-based, and also consider different formats of ways of communication. And then knowing some of the stories can be heavy, and there's things around gender-based violence, different things around burials that came up, even teen pregnancy, just, not making things too heavy, but adding an element of humor within that. And so that kind of set the tone for our interventions from a design perspective as a team. And so to quickly kind of move through here, Abby mentioned earlier around, the gender 19 or the COVID-19 gender matrix and the categories that were set in place at the start. those were the categories that we ended up using for the story making groups. And we actually just assigned, we had 3 or 4 people there in person, and we said, okay, we're going to divide up into these 5 groups and actually figure out, look into the slide decks of all the findings that we have and look at how we can translate that into a story. And so part of that session was looking at, what makes a good story? What are the elements of that? And going back to maybe elementary school when we were doing this for the first time and thinking about, how do you set up the framework for that? And so going through setting, characters, plot, conflict, and theme. And so as a team, we really did that as an exercise, and each of these colors that you'll see on the screen kind of translate to these sticky notes that we brought all the way from Vancouver in a suitcase all the way to Eldoret, and did this exercise up on the wall. And each had about like half a day in the afternoon to kind of look through what all the possibilities would be for the people that could be in the story, the plots in the story, and the core conflicts. And then here you'll kind of see on the side here, this was a draft of some storyboards that we initially started to look at, we have maybe 15 or 20 options. How do we then translate into a really compelling first draft of some notes for a story? And so that was our first step here. And then this was us kind of posting it up on the wall so that we kind of did a round of storytelling and performance there live at the health center. And the core thing I wanted to just emphasize here is that this was category-based storytelling. This was the closest connection to the actual like raw research findings. We used it based on the COVID-19 matrix, gender matrix. And so it was very tightly connected to how we collected information. And over time was how we kind of shifted that to a more narrative-based approach. And so here is, I think, where I will share, where we shared the first iteration of this with the Community Advisory Board. And Susan, who's one of the amazing students that's on the team, she actually like performed it with music and Swahili. And so we just wanted to have a tiny clip here where we share it. And so hopefully it will play. Someone can maybe give me a thumbs up to make sure they can hear the audio.
Chamas. Na kwa haya yote kuna bibi mmoja anayetazama anayeitwa Binamangafulo. So hadithi inapoendelea.
So that's just a tiny clip, but we had each of the 5 teams come up and share it with the Community Advisory Board, and live they were sharing feedback of like, oh, I think you should adjust this, or let's change the characters, or this needs a little bit more clarity. And so that was just one example of how we connected back with the community to refine the next steps. And so from there, the main feedback was, okay, maybe let's not stay too close to the original raw findings from the data and make it a more narrative approach. And so rather than COVID-19 treatment and illness, it became fear of COVID, ripple effects, and how the government adapted to that context. And rather than direct, health-related pieces, how do we talk about teen pregnancy and how that was prevalent through a story in that way? And through resilience and acknowledging that a lot of people passed during this time, rather than talking about death specifically, how do we build it around this idea of, or sharing about burials and how difficult that was, and people not being able to bring their families and loved ones to mourn and grieve during that time. And then similarly, family hardship around, wages and curfews and hunger and food, and, acknowledging that, each of our findings when we collect information, it doesn't just neatly fit into categories. It's really intersectional, and, no thing is, has one facet. It's definitely multifaceted. And so this was our attempt to kind of go from having neat categories into something that kind of transcended beyond that. And so quickly, I'll just kind of move here and share that we went into a storyboarding activity on Miro, where we then gave feedback and added some notes so that the students could go in and refine the stories a little bit more. And then refined it again to then go through now and have chapters of a story where we had a community that we created a name for. We had different characters that we had in that stories, and gave them all roles and jobs and, brothers and sisters and families, and helped build the story out a little bit more. Still connected to the research findings, but now building it out into kind of a more creative kind of approach to sharing that. And so this was, again, just a further refinement, now integrating the illustrator, who's amazing, and did a lovely job of like communicating the local context within Transoya and really, visualizing the written words that we had. And where we're at now is kind of version 4 of the story and looking at how do we build in the pre-context of COVID, knowing that, the sustainability of the story is, in 10 years from now, how would someone look back at COVID and feel like they have an understanding of it? And how could that be communicated beyond everyone who just experienced it, 2 or 3 years out? And so that pre-COVID-19 context, that, rumblings that started happening and the reports that start coming to be was really important for context setting. And, we're continuing to refine this version with the students as we move forward. But that's where we're at in terms of a quick overview. And I'll maybe now pass it over in a few minutes just to Abby to share what those pieces are. But before I dive into that, I just wanted to share that aim 3, we mentioned that we wanted to create a storybook or, a story to share back with the community. And a story can take many different formats. And so this was an exercise that we had taken and done together in terms of mapping all the opportunity spaces that storytelling-based interventions could take. And so some of that was around radio, some of it was the local TV screen that just popped up and came to be within Kenya or in Eldoret, and other approaches through stickers and calendars and TikTok and all these possibilities. And not all of them made the final cut, but we kind of tried an approach to kind of see the depth and breadth of that. And from there, we did this kind of prioritization exercise where we looked at impact versus effort. And this was to really see what are like high impact possibilities that we could take with this project, and what are maybe some lower ones that we can acknowledge but not necessarily dive into. And so from here, some of the selected ones we're looking at, community forums going back to the Chamas, a radio show, a skit, TikTok, or a printed storybook as some options. And now, kind of a year later from this kind of exercise, we're happy to share a few kind of snippets of where we are now. So I'll now pass it back to Abby to share that.
Thank you very much, Nadia. I think she's tried to condense work from several months into a few slides, and I'm sure you know that is a lot of hard work. But this is where we're at now. We have a digital media storybook, and this storybook is focusing on the resilience of the community rather than on the negatives of the COVID pandemic. And we're looking, the key thing I want to just share is that this storybook was really informed by the community's experiences, and the illustrations were depicting a lot of what went on in the community. I remember some of the conversations: should we use this sort of vehicle to depict an ambulance? Is this Kenyan enough? Does it reflect who we are? Are the people well dressed? And so we have a storybook that has been titled Heroes of Mpakani. And if you can move on to the next slide, I'll quickly share with you what we also created. Perfect. We also created a counting book. If you listen to some of the things she shared, we thought that some of the content in the storybook might be a bit too heavy to share with children. So one thing we did was to create a counting book that will be printed to sort of give children sort of a window into the experience that happened during the pandemic. For example, you can see 9 women, and it's showing women in the Chamas meeting with appropriate distancing, teaching about safety protocols. And we're hoping that this would help the children understand what happened during the pandemic. You can also see that on the counting book, we have the words written both in English and in Swahili to sort of make it relevant to the cultural context. Next slide. I think the most interesting piece, although I haven't seen the play, and it's caught on quite quickly in the community, is there was a play that depicted the experiences people had in the community. And at the last time we spoke, it had about 600 or more people that have viewed this, and the response has been very positive to the play. There have also been radio shows that have been depicted. And I want to speak to the fact that a lot of this work has been made because we had funding support from UBC Health in terms of the digital media, and as well as the community workers for showing the plays. I will take a pause here and let Nadia lead us into the knowledge translation lab, our activity to end the day.
Thanks so much, Abby. And so, yeah, we've been talking to you for quite some time now, and we hopefully you'll some inspiration for what different approaches to story-based knowledge translation could look like. And to now get a little bit of a further window into that, we wanted to bring you into what we're calling the Knowledge Translation Design Lab, and engage you in some exercises around how you could think of an activity and different approaches, and using the findings specifically is where we're going to start, but you can translate this kind of knowledge here into your own context. And so what we're going to do for the next, I think I'm just looking at time, and so maybe we can do it for the next 15 minutes, is in groups. We're going to let everyone kind of create a knowledge translation strategy that uses the real findings that Abiola shared kind of earlier from this Chamas for Change research, and consider tailoring that strategy for specific audience. And so, you know, what were the most important message? Again, what was the format, and what was some kind of community engagement strategies that you could consider? We're not going to get through all of it today, but we wanted to set the stage for what the possibility could be. And we'll make sure we send the link so that you can save it beyond this meeting. But what we're going to do is slowly pop into breakout rooms, and then talk through what the findings kind of are and what the audience are. And we have a step-by-step approach that will guide you through each step of that strategy creation. And so just for context, these were findings that Abby had kind of shared earlier around the increased odds of community health worker visits, increased gender-based violence, the economic vulnerability situation, as well as exclusive breastfeeding, with the audience considerations being young mothers, community elders, adolescents, or healthcare workers. And so we're going to ask in groups for everyone to pick a finding and pick an audience, and then have that be the initial context for where you're working through this exercise. But I'll maybe just stop sharing for a moment. And I think we've decided as a team that we might actually narrow down to 3 breakout rooms. And so I'm just going to make that adjustment now, and then we can open those rooms. So, okay.
Would you like me to pop the whiteboard in the chat so everyone can access it?
Yeah, that would be great. And then we'll also share it in the actual room. But thanks so much, Abiola, for doing that. So you can save that link for later, and also access it now. And we'll have a team member from our group facilitate each room. So I think I'll press open the rooms now, and then we'll maybe aim to come back in about 15 minutes. So 3:25. All right, so you should see the pop-up open, and do that now. All right.
We were almost there.
We were mid-sentence, but anyway, we got partway. Hopefully that was a good start to the activity for everybody. I know we were a little bit shorter on time than we were expecting for that piece, but maybe we can just do a little round around how it went in each of those rooms. If everyone just wants to give a quick, maybe 1-sentence piece before we kind of wrap up as we near the end of the session. Maybe I'll look at Justus and Anjellah.
Thank you. I was the lead facilitator in that particular session. So I'll give Angie was our note taker, and Tio will also say something because Tio and Marie were part of our group. So Angie, quickly, just 1 minute.
It was quite interactive, and I think most of the feedback we got was on the different findings that would be best shared. So we agreed on exclusive breastfeeding because there was lots of interest around nutrition, and the target audience was healthcare workers. And then we kind of go back into the plenary when we were looking at the matrix and seeing what was high impact, low cost, among others. So I'll give Tio an opportunity to just say something, then we'll pass it over to you quickly, Nadia. Tio.
Yeah, I was just going to say, I know we're a bit of a smaller group than we started with, so I think it's a fantastic template, and I would encourage the organizers, if you're willing, to maybe provide that as a resource for the folks who attended the session, maybe a blank version of it with some instructions. I think it's a wonderful exercise to go through. So yeah, I'll leave it there.
Thanks to you. All right, and I'll pass it. I think we have Abby, Claudia, Astrid, and I were in the other session, and I can give a quick summary. We just started, I would say, to dig our teeth in, and we also picked exclusive breastfeeding as a kind of option there. But some questions that came up in the session were around, where did some of the quantitative findings come in, and how do those then connect back to the qualitative information? And so I think that was just a good discussion that we started to have around, how do you build in or layer that information and kind of honor where it came from, and acknowledge how complex it can be. And so we started to do that by summarizing we didn't quite get to the matrix piece, but yeah, I don't know if there's anything to share from the exercise, Claudia or Abby, but I think that was mainly our summary from our group.
I think that for me captures it. I found it interesting that we both chose the same finding, but we layered ours with health workers and also young mothers. So we were going to have two groups to interface with in our group. So that would have been really interesting to work on.
Yeah, thanks for that, Abby. And as we now are narrowing the last kind of couple minutes, I'll maybe share screen again just as we wrap up here. And in terms of the template, I know there's a question there. I think we're definitely happy to kind of have a version, and we want to make sure that we have tools that everyone can use and access and take some of what we learned as a team and apply that in your own setting. Okay, so on that note, as we are looking kind of forward here, we just wanted to share here kind of a photo that we have, again, as an aerial view from the Chamas session. And I think, Astrid, when we were on a call, I think last week, we kind of both were looking at this and we're like, oh, it looks like a heart. And it's so nice to kind of see this from the sky, how much love and care kind of comes from this kind of project. And it's always nice to kind of ground this work back in the community context and the women and families that are there. And from this view, I can actually see you, Angie, in there, which is kind of nice, as well as some other team members from our team. Okay, and so I think our main kind of last thing as we wrap up in this session kind of together was thinking about, how can you apply storytelling-based knowledge translation strategies to your work? And we hope that you're kind of inspired a little bit to start that journey or add to what you have so far. So if you have any kind of questions, we'd love to kind of take those now. And we just want to kind of acknowledge there's so many people on this team that are part of this work, even more than we have even listed here within the community as well. And a special thank you to the kind of work study students and Illustrator for their dedication really over the past year to this, which has been amazing. And acknowledgement to the many, many partners that are part of this project over a decade plus. And yeah, if there's any questions or comments, we'd love to take those now. And I'll leave this email up here of both Astrid and Julia from the team in case if there's questions.
Yeah, and Nadia, I guess, I'll let Claudia go ahead. There you go.
Sorry about that.
Yeah, no, please go ahead.
I thank you very much for this really, really informative presentation. I'm very, very much inspired by this work. I'm wondering, do you have any recommendations, like your approach and your methods that you use? Do you have any recommended readings that you might suggest on your approach?
Yeah, I could definitely put a list together for you, Claudia, on our approach. I think another just general area that you could kind of consider looking into is co-design. And co-design kind of has this layered approach of how do you do work directly with community and consider them in each step of that process. And so that's kind of a larger kind of design research like sub area that is important to kind of like maybe look into if you're interested, but I could give you some links there. Yeah.
It's not so much the co-design part, but more how do you translate it into a story, that process.
Okay. Yeah, for sure. Yeah. So I think from a design perspective, I can definitely put some kind of links there. Happy to do that. Yeah. Okay.
would like to thank UBC Health again too for helping us organize this. You made it very easy, very supportive. So really appreciate that.
Yeah, I will say we did not make it easy for Angie and Justus and Sheila and maybe Violet, who are in Elder Ed Kenya, and we are very thankful that you were able to accommodate our calendar and our time zone between us, and so
Always a pleasure.
good morning for you guys officially.
Always a pleasure.
Thank
Nice.
you so much.
Yeah.
You should have told us to wear black as well.
We didn't give you the memo.
I didn't get the memo. Even Theo is wearing black. Nadia is wearing. Even actually, I'm the only one not wearing black. Yikes!
I reliably wear black, so it was just a happy coincidence. But yeah, I wonder. I was just going to say a couple words to wrap up, and then we can go on our way. I guess on behalf of UBC Health, just wanted to extend thanks to this whole group for creating today's dialogue session. And I think we've all learned a lot about how we can potentially apply some of these approaches in our own work. And so I think we can also look forward to continuing some of these conversations and collaborations through other UBC Health ongoing initiatives. So in addition to today's sessions, we have several other Health After 2020 sessions coming up in March and April. There's a link to our events page, and we'd also like to highlight the Bridging Research and Action event, which will be happening in May on both UBC campuses, both in Kelowna and Vancouver. So there's links in the chat. And lastly, I'd like to highlight our partners in this program. The Knowledge Exchange Unit will be hosting the Partnering and Research Conference in June. So encourage everybody to check that out. And we'll be in touch with all of the folks who attended today to share some resources, the recording, and hopefully get some evaluation input. So thank you very much and enjoy the rest of your day.
Thank you so much. I really appreciate it.